Hi, everyone. I'm Ross Brownson. I'm with Washington University in St. Louis, where I'm a professor there and director of the Prevention Research Center. And I am with you today to talk about administrative evidence-based practices, or the shorthand we'll be using called AEBPs. This framework, and the AEBPs, as we call it, is what we call a small p policy framework. Small p policy is really organizational policy. So a clinical practice or a public health agency, and the policy around that might be an organizational guideline, it might be an interagency decision or a memorandum, or it could even be the social norms that develop over time around how an organization works. That can involve the climate and culture of an agency. And that's different than big P policy, which involves formal laws, rules, regulations, typically in westernized society, policies or laws that have been enacted by some democratic form of government. For example, in the United States, that would be the Congress or a state legislature or a local city or county council. And so today, we'll be talking about these AEBPs. This is the framework for the AEBPs that we developed, and be glad to talk about that as we go through today.
Thank you for the introduction, Dr. Brownson. My first question for you today is, can you describe in a few sentences how this framework came about and how it is used now?
Yeah, I'd be glad to. So the framework, as you see depicted here, the AEBPs, they're agency level. We worked in health departments, but they apply just as equally in a clinical practice. They have been used in non-governmental organizations as well. These are agency level structures and activities that are positively associated with performance measures. So if you look over here on the left-hand side, you've got scientific knowledge, you've got evidence-based practices, you've got stakeholder input, and on the right-hand side, you want your agency or clinical practice to perform better, and you want to have higher adoption of these EBIs, or evidence-based interventions. And so the AEBPs framework, we identified first back in 2012. We did a review, what was called a review of reviews. Instead of looking at original articles, we looked at 20 different empirical reviews. This is a project that was funded by the Robert Wood Johnson Foundation under what they call PHSSR, Public Health Services and Systems Research. And we've also been supported by CDC and the NIH. Unlike the vast literature in D&I science, these AEBPs help us at least begin to tell the story of not what an evidence-based intervention is, but how we form an evidence-based organization. And again, this is an example, and we'll talk more about some of the parts of this in the middle, but this is an example of small p policy that helps an organization make better use, more efficient and effective use of resources.
Awesome, thank you. I think we're ready to hear about these key components of this framework that you have depicted in the middle here. Can you describe those a little more?
Yeah, I can. So if you look in the middle, and I'm going to start kind of around on the left-hand side on workforce development, there are 5 core elements that we'll call domains of our AEBPs framework. The first is workforce development. That is things like, what is the training background of the workforce? What is the credentials? Are they, do they have master's level training, doctoral level training? Do they have access to technical assistance and ongoing workforce development, sort of on-the-job training? Embedded in that is the idea of lifelong learning. Then next becomes leadership as a second major domain. That is the skills and the background of the leaders, involve integrity, the values, the expectations, whether a leader involves the other staff and employees in decision-making, the idea of participatory decision-making. So leadership is the second core element. The third core element there on the upper right is the organizational climate and culture. That obviously relates very closely to leaders as well. That can involve innovation. Does an organization foster innovation? Does it allow you to take risks? Do they have access and free flow of information? We found, many organizations you probably worked in, there can be bottlenecks where maybe the bosses hear about something, but the frontline employees don't. And so that's the idea of a climate and culture that supports evidence-based decision-making. The fourth area is financial practices. That involves allocation and expenditures of resources, the funding base for an organization, the transparency in finances, those come into play within that financial domain. And then the fifth involves relationships and partnerships. That could be relationships both within and outside an organization. Who are your partners? Let's say you're working with a whole set of clinics that are trying to deliver care to an underserved population. What is that network of clinics? Do they have a common vision and mission statement? Do they share resources? Do they have reciprocity in decision making and sharing power? And so all those things come into play in that fifth domain of relationships and partnerships.
Excellent. Next, can you describe what makes AEBPs and this small p policy framework especially well suited for planning pragmatic research?
Yeah, I'd be glad to do that. I guess the basic bottom line is the original development of this based on the review of reviews I mentioned earlier, which is the citation at the bottom of the figure here, and then the actual operationalizing it occurred in practice agencies, in state and local public health agencies, governmental, non-governmental agencies. That makes it sort of almost pragmatic in its origin, but it reflects the real world of practice. So it's not just an academic theory that hasn't shown real data from public health practice. The individual pieces of this that we'll talk a bit more about in a minute can be measured. They can be summarized in a report card-like format, so they can lead toward quality improvement. All the metrics I talked about earlier when I was talking about the 5 domains, the individual subparts of those, which tend to end up in between 19 and 25 individual factors, depending on how we frame it. They were set up to be action-oriented and changeable with a relatively short time frame, which we defined as less than 3 years. And so that is kind of the real world orientation that we tried to bring to our framework that we think does make it pragmatic.
Great, thank you for sharing. Next, I'm going to ask if you can describe a couple of examples when you've used this framework for planning pragmatic research studies in the past or in ongoing studies.
Yeah, so, and I'll probably highlight a few different studies. I don't know if it'll be a couple, but at least it'll be a few, I guess several. We've conducted a series of national studies of local public health agencies using 19 specific items within those 5 domains that you see in front of you. We first collect descriptive data. We did validation of the measures. We did that with about 500 local health department directors. And then we've also used this AEBP's framework among local program managers in infectious disease, environmental health, and chronic disease control. And what we want to do there was not only validating the framework, but look at the agreement between people on the front lines in these programs compared to the leaders of the agency, which is typically the director of a local health department or the deputy director. That gives us some of the quantitative data. We've done also qualitative use of these. You think about sort of the quantitative data, it tells you the what and the how much around these AEBPs. It doesn't tell you about the how. In other words, if you've got an agency that wants to do better, how do I do that? And so in the qualitative work we've done, we sampled high and low performing health departments based on the quantitative data. And then we interviewed staff from these agencies to try to figure out why one agency that otherwise looks the same is doing much better on these than another. We've used these also in a series of empirical studies, large scale implementation science studies with state and local public health practice Most of these funded by the NIH, but also some funded by the CDC. And then most recently, we're using this AEBB's framework with ASTHO, which is the Association of State and Territorial Health Officials, which is a non-governmental organization, and it works with really the leadership of state public health agencies, of course, now working almost solely on COVID. And we've done this kind of in the midst of COVID, try to understand how they're doing and how they can make their organization more evidence-based. So it's kind of a parallel to what a health department or clinical practice would do, but it's somewhat at a higher level that's working across all of the United States, not just in a certain locality.
Awesome, thank you. One last question for you today. I already asked about when your framework is good for pragmatic research, but can you describe some key challenges or possible pitfalls with using this framework for the same kind of research?
Yeah, so this probably isn't different than almost any other pragmatic framework, but one, these data, to get these data, although it's a short questionnaire, it takes probably 5 to 8 minutes to fill out if we use the 19-item questionnaire. It does require new data collection. So, you know, there are some measures of performance that we could get from existing administrative data, you know, charge data or other data that we could get a hold of. These sorts of data on AEBPs does require new data collection. We have worked mostly in public health settings so far. So another limitation is that it hasn't been tested across a wide variety of settings, although we have tested it both in state and local public health. So in a clinical setting, I think this would apply, but you would have to modify some of the things because the flow of a clinical practice and patient flow is a little different than your typical local public health agency, although a number of them do provide clinical care as well. And then, you know, probably significant now more than ever is these settings change over time, especially in COVID world. I know a lot of the local agencies we work with are very constrained. There's some of them that are at risk of going out of business now. And so how this measures change over time may be different. There may be some things we need to measure differently, you know, pre-COVID compared to post-COVID within both the 5 broader domains and the individual factors within those domains. And so we always need to be aware that you know, public health practice, clinical practice is dynamic. We want to make sure that any of our pragmatic frameworks remain dynamic as well.
Awesome. That's all the main questions I have for you today. And just to finish, I was wondering if there's anything else that our viewers or our audience needs to know about administrative evidence-based practices or this framework.
Yeah, I guess only that, you know, this is one of many different frameworks that you can use to assess small p policy. I know you've heard about some of the other ones already. And so if this one seems useful to you, feel free to reach out to me. We have an online tool that you can use for this, and I'm glad to share our experience both through journal articles, but also more broadly in sort of how this has been applied and when it's been useful and when not. So I just would say feel free to reach out to me if you have any questions or comments.
Awesome. Thank you, Dr. Brownson, for taking the time to interview with me today and go over this framework with us today.
Yeah, thank you, Jordan, and I'm glad to talk with you, and we'll look forward to hearing from participants as we go along.